So I want you to imagine an organ that's basically designed to act as this heavy-duty biological cement mixer.
Right, something that's constantly moving.
Yeah, exactly. It's lined with these thick, muscular walls that are capable of, like, really violent, crushing contractions. And it routinely fills up with hydrochloric acid.
Which is, I mean, that's acid corrosive enough to literally dissolve metal.
Exactly. And its entire job, day in and day out, is to just systematically churn and break down and, liquefy whatever you throw down your throat.
It's a pretty intense environment in there.
It really is. But now I want you to imagine that entire churning vat suddenly just snapping off its internal moorings and doing a literal 180-degree flip inside your body.
I mean, honestly, it sounds physically impossible when you put it like that. We naturally assume our internal organs are just, firmly bolted down, like they're permanent fixtures in the abdominal cavity.
Right, like plumbing set in concrete or something.
Yeah, exactly.
But the reality of human anatomy is, it's far more precarious. So welcome to another deep dive. Today, we are taking a really fascinating stack of medical case studies, some historical surgical literature, and modern radiological research to unpack one of the most bizarre and terrifying structural failures of the human body.
It really is wild.
Yeah. We're looking at a condition called gastric volvulus, which in plain English is just a twisting of the stomach.
Which sounds awful.
It does. And we're going to explore how the anatomical rigging that hold us all together can suddenly fail. We'll look at a 100-year-old physical exam trick that emergency room doctors actually still rely on today.
That's one of my favorite parts of this.
Oh, it's so cool. And we'll also navigate the incredibly high-stakes tightrope that modern surgeons have to walk when they're deciding whether to cut a patient open or just sit back and watch.
Right. And to really grasp the mechanics of this, I think we need to establish a baseline of what a normal stomach looks like in its natural habitat, and how it was actually discovered that things could go so catastrophically wrong in the first place.
Oh, for sure. And the historical anchor for this condition takes us all the way back to 1866.
Right. Over a century and a half ago, which is crazy.
Yeah. I mean, this is an era way before X-rays, before any kind of modern imaging. You only found out what was wrong with someone's internal organs after they had already passed away.
Yeah, that is the grim reality of 19th century medicine. So there was this physician named Berti, and he was performing an autopsy on a 61-year-old woman who had died after just this bout of severe, completely unexplainable abdominal distress.
And he didn't find what you'd expect, right?
No, not at all. When he opened the abdominal cavity, he didn't find a tumor or, an infection. He found a mechanical impossibility. He documented the very first recorded case of a human stomach twisted completely upon itself. Yeah. And to understand his shock, we kind of have to talk about how the stomach is secured in the body, because it isn't just this balloon floating freely in the void of the abdomen.
Right, it's not just hanging out in empty space.
Exactly. It is a highly active muscular organ, so it requires some heavy-duty biological rigging to keep it in place while it churns.
Yeah, I was actually trying to visualize this when I was reading the source material. If the stomach is violently contracting to mash up food, it needs resistance, It needs to be tethered down so the muscles can push against something. And the sources detail 4 major ligaments acting as these tethers. They essentially form like a biological hammock.
Yeah, that hammock visual is actually the perfect way to look at it. You basically have tension pulling from 4 different directions. So first, pulling to the left, you have the gastrosplenic ligament.
Okay, let's break down the medical Latin real quick for the listener.
Good idea. So gastro means stomach, and splenic refers to the spleen. This is a thick band of tissue that anchors the stomach to the spleen.
Okay, so that's the left anchor. Got it.
Right. Then, anchoring it downward, you have the gastroduodenal ligament. This connects the very bottom of the stomach to the duodenum, which is the first section of the small intestine.
Okay, left and down.
Yeah. Third, anchoring the top of the stomach upward is the gastrophrenic ligament. Now, chorionic refers to the diaphragm, which is that massive sheet of muscle right under your lungs.
Right.
So this ligament tethers the stomach to the ceiling of the abdominal cavity.
Okay, so we've got left, down, and up. There's got to be one more to complete the whole suspension system.
Yep, the gastrohepatic ligament. Hepatic meaning liver. So this pulls tension to the right side of the body, anchoring the stomach to the underside of the liver.
Wow. Okay.
So these four anchors maintain the stomach's precise position. They allow it to expand when you eat a huge meal and, contract when it's empty, but they prevent the organ from actually rotating.
But when those ligaments fail,
Yeah. When there is abnormal laxity, or they stretch out, or they get somehow surgically disrupted, that's when the trouble begins. The mooring lines snap, and the ship is essentially loose in the harbor.
and when that ship breaks loose, based on the literature we are reviewing, it doesn't just, like, drift aimlessly. It violently capsizes.
It does.
But it doesn't always capsize in the same direction, which is super interesting. There seem to be two very distinct mechanical ways this muscular bag can twist by more than 180 degrees.
Yeah, and the direction of the twist dictates the entire trajectory of the condition. I mean, it is literally the difference between a chronic, annoying tummy ache and a lethal catastrophe.
Okay, so let's get into the two types.
So the first, and honestly most common type of twist, is called an organoaxial volvulus. This accounts for roughly 60 to 80% of all adult cases we see.
Okay, I really want to break down the geometry here because the terminology in the sources is pretty dense. Organoaxial. The sources say this twist happens along the cardiopyloric line. So let's translate that for everyone. If we picture the stomach as this J-shaped bag, you have the top entrance where the esophagus comes in from the throat. That's the cardia or the gastroesophageal junction.
Right.
And then you have the bottom exit where the food drops into the intestines. That's the pylorus.
Yes. So imagine drawing an imaginary line straight through the stomach, connecting that top entrance to the bottom exit. That is the long axis, the cardiopyloric line.
Okay, got it.
So in an organoaxial volvulus, the stomach rotates around that long axis. The bottom curve of the stomach, the antrum, flips up and forward. Meanwhile, the top curve, the fundus, flips down and backward.
So the stomach essentially just rolls over on itself.
Exactly.
Let me try an analogy here because my brain honestly keeps getting stuck on how a hollow sac actually twists like that. If the organoaxial twist is a long axis roll, is it basically like taking a wet towel, holding it by both ends and wringing it out?
Yes, that's spot on. And when you wring out a wet towel, notice what happens to the physical structure of the fabric. The center tightens up immensely, the fibers compress, and the two ends are pinched completely shut.
Oh, well, yeah.
So in the human body, that wringing motion creates what surgeons call a closed-loop obstruction. Both the entrance of the stomach and the exit are kinked closed. Nothing can enter, and absolutely nothing can leave.
Which means any gas being produced by the bacteria in your food or any acid being secreted by the stomach lining, it's all just trapped. The pressure just builds and builds.
The pressure buildup is severe, yeah. But the true danger, the really scary part, is what happens to the blood vessels.
So the stomach has a huge blood supply, right?
Huge. It's wrapped in this rich network of arteries and veins. So when you wring the stomach like a towel, you are violently wrenching those blood vessels. You kink them shut. And the veins usually compress first because their walls are thinner.
Okay.
So blood can still pump into the stomach tissue through the thicker arteries, but it can't drain out through the veins.
Oh, no. So it just swells up.
Exactly. The tissue becomes massively engorged, swollen, and just angry.
It's like tying a rubber band really tightly around your finger. Turns red, then purple.
Precisely. And as the swelling increases, the pressure eventually overcomes those thicker arteries too, cutting off the incoming blood supply completely. This is called ischemia tissue starvation.
Meaning the cells in the stomach wall are deprived of oxygen?
Yeah. And without oxygen, the cells begin to die off rapidly. This is necrosis, or gangrene of the stomach wall.
Which is terrifying.
It is, because healthy stomach tissue is incredibly robust. I mean, it has to be to handle stomach acid. But necrotic, dead stomach tissue becomes paper thin and structurally incredibly weak.
Oh, I see where this is going.
Yeah. Eventually, the trapped pressure inside the stomach simply punches a hole right through the dying tissue.
A perforation.
Yes.
So that vat of acid and bacteria just bursts open into the sterile abdominal cavity.
Which is an absolute 5-alarm surgical catastrophe. That is the grim reality of the organoaxial twist.
Okay, so that's the wringing towel. What's the other type?
Right, so the second type of twist is the mesenteroaxial volvulus. This accounts for a smaller slice of the pie, about 20 to 29% of cases. Interestingly, we actually see this presentation much more frequently in pediatric patients, in children.
So if the organoaxial twist is rolling around the long axis, the wringing of the towel, what is the mesenteroaxial twist doing? The sources say it rotates around the short axis, the transgastric axis.
Okay, so the transgastric axis is an imaginary horizontal line that cuts across the middle of the stomach. It bisects the lesser curvature on the inside and the greater curvature on the outside.
Okay, a horizontal line.
Right. So in a mesenteroaxial volvulus, the stomach rotates around this horizontal line. The stomach essentially folds in half. The bottom part of the stomach, the antrum, flips completely upward, bringing it physically above the top entrance, the gastroesophageal junction.
So sticking with the towel analogy, this isn't wringing it out. This is just taking the bottom edge of the towel and folding it up to meet the top edge.
Exactly, just a simple folding motion. And that simple geometric difference changes the pathology entirely.
How so?
Because you are folding the stomach rather than twisting it like a corkscrew, you are far less likely to completely strangle those blood vessels.
Okay, that makes sense.
Yeah, the rotation is often partial, maybe less than 180 degrees. The blood supply stretches, sure, but it rarely cuts off entirely. And because the blood flow is less compromised and the tissue isn't rapidly dying, the stomach often spontaneously untwists.
Like the towel just unfolds on its own.
Exactly.
So the patient gets this sudden, sharp pain, feels incredibly full or nauseous, and then like an hour later, the stomach slips back down and they feel totally fine.
Yeah, it leads to intermittent chronic symptoms rather than an immediate explosive emergency. The patient basically becomes trapped in this cycle of folding and unfolding.
It is genuinely fascinating that simple geometry, a roll versus a fold, dictates whether you are experiencing a chronic, grumbling tummy ache or a literal life or death surgical crisis.
It's all mechanics.
Yeah. But this naturally brings up the question of causation. Like, okay, if physical trauma can knock the stomach loose or if ligaments stretch over time, what happens if someone's internal anatomy is just, built wrong from the start? What causes the suspension system to break down in the first place?
Right, the why. So the medical literature divides the causes into two distinct categories. Type 1, which are primary causes, and type 2, which are secondary causes.
Okay.
Now, primary gastric volvulus is surprisingly the minority of cases. It only makes up about a third of all diagnoses. This is where the root cause is a fundamental issue with those 4 guy wire ligaments we talked about.
So they were just structurally deficient.
Yes, it can be congenital. A patient is simply born with ligaments that are too long, too loose, or sometimes even entirely absent. Or it can be acquired over a lifetime. Just as, the skin loses elasticity as we age, the internal connective tissues can lose their tensile strength.
That makes sense.
But the vast majority, roughly 2/3 of all cases, fall into the type 2 secondary category.
Meaning there's a completely different architectural failure somewhere else in the abdomen, and the twisted stomach is really just collateral damage.
Exactly, a secondary consequence. These underlying structural issues usually involve the diaphragm, for instance. Diaphragmatic defects, where the muscular sheet separating the chest cavity from the abdomen literally has a hole in it.
Right.
Or hiatal hernias, where the upper part of the stomach is physically pushing up through the natural opening in the diaphragm and entering the chest.
Ouch.
Yeah. Blunt force trauma, like a severe car accident, can also tear the ligaments. And, perhaps most ironically, previous abdominal surgeries can cause it.
Wait, surgery causes it?
Yeah. Scar tissue from an old operation can form these tough fibrous bands called adhesions. These adhesions accidentally create a new, unnatural pivot point for the stomach to catch on and spin around.
Wow, okay. I want to dig into a couple of specific cases from the sources because they perfectly illustrate how sneaky and bizarre these primary and secondary causes can actually be.
They're pretty incredible.
Yeah, so let's look at a primary congenital case first. This is a pediatric case detailed in the literature, and it honestly reads like a medical mystery.
Okay.
We have this very young child who presents to the hospital with intractable vomiting, and I mean severe, nonstop vomiting. They have 3 separate, terrifying episodes of this. And the underlying cause hiding in the child's abdomen was something called a wandering spleen.
Oh, yeah.
I have to be honest, wandering spleen sounds like a fake disease from a Victorian medical journal.
I know it sounds whimsical, but it is a very real and very rare embryological anomaly.
What exactly is it?
So during fetal development, the organs form and rotate into their final positions, and the peritoneal lining fuses to create those anchoring ligaments we discussed earlier. In this child's case, there was a congenital failure of those normal intraperitoneal visceral attachments.
So the ligaments didn't form.
Right. The specific ligaments that are supposed to glue the spleen into the upper left quadrant of the abdomen simply failed to develop.
So the spleen isn't anchored to the abdominal wall at all? What holds it in?
Nothing but its blood vessels.
Oh, wow.
Yeah. The spleen is a solid, fairly heavy organ, and it's filled with blood. Without its structural anchors, it was literally wandering around the child's abdominal cavity on a long, extended vascular pedicle. Depending on how the child moved or laid down, gravity would just pull the spleen into different sectors of the abdomen.
Which is wild enough on its own. But we were talking about twisting stomach here. How does a roaming spleen cause the stomach to fold in half?
It comes back to the biological hammock. The stomach and the spleen share a wall of attachments, specifically the gastrosplenic ligament. They are connected to each other.
Right, okay.
So if the spleen's external anchors to the abdominal wall are missing, the spleen drops. And because it is still tethered to the stomach, that heavy, wandering spleen pulls the stomach down with it.
Ah, I see.
Yeah, that massive shift in weight initiates the exact mesenteroaxial fold we just described. The stomach folds in half because it's literally being dragged down by the spleen.
That is insane. But the tension in this specific case study isn't just the weird anatomy, it's how the diagnosis was repeatedly accidentally hidden from the emergency room doctors.
The clinical irony here is astounding. Let's look at the sequence of events.
Yeah.
During the first 2 episodes of the severe vomiting, the parents rush the child into the emergency room. The standard medical protocol for severe, intractable vomiting to prevent the child from aspirating fluid into their lungs and to decompress the stomach is to insert a nasogastric tube.
An NG tube, the plastic tube that goes down the nose, down the back of the throat, through the esophagus, and into the stomach to pump out the fluid.
Exactly. So the ER doctors place the NG tube, and it works perfectly. The vomiting immediately stops. The child gets relief.
Which sounds like a win.
It does. But here is the mechanical blind spot. The mere physical act of pushing that semi-rigid plastic tube down into the stomach acted as an internal splint.
Oh.
The physical force of the tubing sliding in unknowingly unfolded the stomach. The tube straightened it out.
So by the time the child stabilizes and the doctors wheel them down to the radiology department for a CT scan to see what caused the vomiting, the scan is completely clean.
Yep.
The stomach looks perfectly normal because the tube is holding it in the correct position. They accidentally cured the symptom and erased the physical evidence at the very same time.
It is a phenomenal example of how dynamic this condition is. You are dealing with moving parts. It wasn't until the child returned for a 3rd episode of uncontrollable vomiting that the medical team realized they needed to change their sequence.
They caught on.
Right. They suspected something transient was happening. So they decided to image the child before placing the therapeutic NG tube. They left the child in distress just long enough to get the scan.
And there it was.
Exactly.
The scan caught the thief in the act. The stomach was folded completely in half in a mesenteroaxial twist, and the wandering spleen was caught on camera, hovering far from where it belonged in the upper left quadrant.
It requires a really high index of suspicion from the physicians. They had to outsmart the shifting anatomy.
Okay, so that perfectly illustrates a congenital primary issue. The ligaments were missing from birth. But there's another case in our sources that I found equally fascinating because it involves an acquired secondary cause. And the surgical irony of this one is just staggering.
The Nissen fundoplication case?
Yes. We're looking at a 60-year-old female patient who developed an acute gastric volvulus. But the timing is the key here. She developed the twisted stomach 4 months after undergoing a major abdominal surgery. She had a laparoscopic Nissen fundoplication to fix a giant hiatal hernia.
Right. Now, a Nissen fundoplication is one of the most common anti-reflux surgeries performed globally. Let's break down why she had the surgery in the first place. She had a giant hiatal hernia.
Okay.
The hiatus is the small hole in the diaphragm that allows the esophagus to pass from the chest down into the abdomen to meet the stomach. In a hiatal hernia, that hole widens, and the top of the stomach physically slides up through the diaphragm and sets up shop in the chest cavity sitting right next to the heart and lungs.
Which causes massive acid reflux, chest pain, and breathing issues. Because obviously the stomach doesn't belong in the chest.
Exactly. So in a Nissen fundoplication, surgeons go in laparoscopically using small cameras and long instruments, and they physically pull the stomach back down into the abdominal cavity where it belongs. They repair the hole in the diaphragm.
Right.
But to ensure the stomach doesn't just slide right back up into the chest, they perform the wrap. They take the top part of the stomach, the fundus, and they literally wrap it around the lower part of the esophagus, like a hot dog bun wrapping around a hot dog, and they stitch it in place.
So it creates a bulky, muscular collar around the esophagus.
Yes. That collar is now physically larger than the hole in the diaphragm. It acts as a permanent plug. The stomach physically cannot slide back up into the chest.
Okay, so here's where my mind hits a wall.
Okay.
If a Nissen fundoplication is literally designed to anchor the stomach in place, plug the hernia defect, and lock the anatomy down. How on earth did this woman end up with a violently twisting stomach just 4 months later?
It's a great question.
Did the surgery fail? Did the wrap come undone and let the stomach spin out of control?
You are hitting on the exact paradox the surgeons faced when she arrived in the emergency room in acute distress. When she presented with the volvulus, the surgical team assumed their previous work had catastrophically failed.
Naturally.
They assumed the stitches tore out, or that massive scar tissue adhesions had formed and tangled the stomach into a knot, so they rushed her into the operating room for an open laparotomy. They cut her open, expecting a complete disaster zone.
And what did they find?
Well, when they looked inside, they found a pristine surgical field. The original Nissen wrap was completely intact. The stomach was still firmly collared to the esophagus, and there were 0 surgical adhesions.
Wait, so what caused the stomach to twist if the surgery held perfectly?
It comes back to the guy wires. Remember, her original hiatal hernia was classified as giant. A massive portion of her stomach had been living in her chest. To pull a giant hernia out of the chest cavity and drag it back down into the abdomen, the surgeons had to perform what is called massive mobilization of the stomach.
Meaning they had to cut away the natural tethers to free it up.
Exactly. To physically move the stomach that far, they had to systematically cut and loosen a tremendous amount of the natural connective tissue, the gastrosplenic, the gastrophrenic ligaments. They severed the biological hammock to free the organ.
Oh, wow.
This necessary surgical mobilization inadvertently created the exact same severe ligament laxity that we see in the primary congenital cases. The very top of the stomach was securely, perfectly collared to the esophagus, but the rest of the massive stomach organ was now hanging completely loose in the abdomen, entirely untethered.
The surgical wrap held the top tight, but the bottom was left swinging in the breeze.
It is a rare paradoxical consequence of advanced surgery. The very act of fixing one severe structural defect, the hernia, demanded the anatomical freedom that eventually allowed for a completely different structural catastrophe, the volvulus.
You fix the mass, but you accidentally loosen the sails.
Exactly.
These 2 cases perfectly highlight how invisible this condition can be until the trap snaps shut. That child's NG tube accidentally hid the diagnosis. The 60-year-old woman's prior, highly successful surgery masked the underlying risk.
Yeah.
Which brings us to the most critical part of this puzzle. When the trap does snap shut, when the stomach twists and the clock starts ticking on tissue death, how do doctors actually identify this invisible twist from the outside?
And the clock ticks very, very loudly with this condition. When a patient arrives in the emergency department in agony, the clinical presentation relies heavily on a fascinating intersection of medical history. The diagnosis is often built on a physical exam finding from over a century ago, combined with the absolute cutting-edge radiological imaging of today.
Let's start with the history, because I love when century-old medicine is still relevant. The year is 1904. A physician named Borchardt is studying these twisting stomach cases, and he identifies a pattern, a triad of symptoms that reliably predicts the condition.
Borchardt's triad. It is incredibly elegant in its simplicity, and remarkably, it is seen in up to 70% of acute organoaxial cases today. Any emergency physician worth their salt looks for it.
What are the 3 signs?
So, the triad consists of 3 distinct clinical signs. First, severe, sudden epigastric pain. This is pain right in the upper middle of the abdomen, just below the sternum.
Okay.
Second, violent, uncontrollable retching, but without the ability to actually vomit up any stomach contents.
Right.
And third, the physical inability for a physician to pass a nasogastric tube down through the esophagus and into the stomach.
Okay, let's unpack the mechanics of that triad, because it maps perfectly to the physics we discussed earlier. The severe pain is obvious. The tissue is being stretched and starved of blood.
Right.
The retching without vomiting makes complete sense based on the closed loop obstruction. The stomach is violently spasming to expel its contents, but because the twist has pinched the top exit completely shut, nothing can come up. The patient just dry heaves in agony. But there's another pain symptom mentioned in the sources that I found really curious. It's referred pain. Patients might present with severe pain at the very top of their left shoulder.
Yes. That is a classic vital physiological clue. It all comes down to the wiring of the nervous system. As the stomach twists and the blood vessels engorge and eventually tear, the stomach begins to bleed internally. That pooling blood, or sometimes just the massive swelling of the stomach itself, pushes up and physically irritates the underside of the diaphragm.
The phrenic nerve.
Exactly. The phrenic nerve innervates the diaphragm. But the phrenic nerve shares a neurological pathway in the spinal cord with the nerves that innervate the shoulder.
Oh, that's fascinating.
So the diaphragm is screaming in pain, but the brain misinterprets that incoming nerve signal as originating from the left shoulder tip. If a patient comes in with a swollen, painful abdomen, violently dry heaving, and complaining that their left shoulder is throbbing, the physician's mind should immediately jump to a subdiaphragmatic emergency like a volvulus.
That is so wild.
Hmm.
But the third part of Borchards' triad, the failed NG tube, is really the hinge of the diagnosis. I want to drill down on this because we literally just talked about the child with the wandering spleen where the ER doctors easily slid the NG tube down and untwisted the stomach.
Right.
But here in Borchards' triad, the defining feature is that the tube physically will not pass.
Mm.
Why does the tube cure one patient and get completely blocked in another?
It is the perfect diagnostic differentiator. It all goes back to the geometry of the twist. In the child's case, it was a mesenteroaxial twist, the short axis fold. The stomach folded upward, but the actual gastroesophageal junction, the doorway from the esophagus into the stomach, often remains relatively open during that folding motion.
So the angle changes, but the door is unlocked.
Exactly. The tube slides right in and pushes the fold open.
But Borchards' triad is looking at the other twist.
Yes. Borchards' triad is specific to the organoaxial twist, the wringing of the wet towel. When the stomach rolls on its long axis, it creates a tight corkscrew kink right at the lower esophageal sphincter.
Ah, I see.
The doorway isn't just angled, it is violently twisted shut. When the physician tries to pass the semi-rigid plastic NG tube down the esophagus, it hits a literal physical dead end. It will not budge.
Wow.
That simple physical blockage tells the emergency physician exactly what kind of rotation and what level of ischemia they are likely dealing with.
It's amazing that a cheap piece of plastic tubing can be a highly specific diagnostic instrument. But medicine has obviously evolved past the physical exams of 1904. We trace the imaging evolution in the sources, and it's a steady march toward absolute clarity.
Absolutely.
When a patient presents with these symptoms, you start with basic plain X-rays of the abdomen. The sources say X-rays might show a retrocardiac gas-filled viscus, which basically means a pocket of gas trapped in an organ hiding behind the heart, or a double air fluid level, showing trapped liquid pooling in two different pinched-off segments of the twisted stomach.
Plain X-rays are fast, but they are just breadcrumbs. They give you hints, shadows of a problem. Historically, the next definitive step was an upper GI barium swallow.
How does that work?
You take the patient into the fluoroscopy suite. You have them drink a thick, chalky, radiopaque liquid barium, and you watch it flow down their esophagus under a continuous real-time X-ray. It is incredibly effective.
Yeah. The studies show it has an 81 to 84% diagnostic yield.
Right. You literally watch the white barium hit the twisted kink and stop dead. Or, if it's a partial twist, you see the classic upside-down stomach shape filled with dye.
That sounds definitive, but there's a massive, glaring problem with that test in an emergency setting. You are asking a patient who is in sheer agony, violently and uncontrollably retching, and potentially experiencing active gastric tissue death, to casually sit up and drink a giant cup of heavy, chalky barium.
It is a miserable, often intolerable test for the acute patient. They usually vomit the barium right back up, or worse, they aspirate it into their lungs while choking.
Which is awful.
Yeah. Which is why MDCT multidetector computed tomography is the absolute undisputed gold standard today. It is fast, the patient just lies flat, it's non-invasive, and it provides a highly detailed three-dimensional cross-sectional map of the entire abdomen in seconds.
And the sources detail a very specific landmark study on the use of CT for this exact condition. The study is by Millet and colleagues, published in the journal European Radiology.
Yes.
They wanted to move past just looking for vague shadows. They wanted to know exactly what specific reproducible signs on a CT scan definitively prove that the stomach is twisted.
The Millet study is a cornerstone in modern radiological diagnosis. It changed how radiologists read these scans. The design was elegant. They took 10 patients who had surgically confirmed acute gastric volvulus. They knew these patients had the condition because they had opened them up. They took their preoperative CT scans and mixed them with 20 control subjects who just had normal, everyday distended stomachs, maybe from overeating or a mild blockage. Then 2 independent radiologists reviewed the images blindly, looking for specific anatomical markers that could tell the difference.
And the findings they published were incredibly decisive. They found 2 direct signs on the CT scan that had a 100% sensitivity and 100% specificity when seen together. 100%. You almost never see perfect numbers like that in biological studies.
You rarely see 100% in anything involving the human body.
Yeah.
The 2 signs were highly specific structural anomalies. First, they identified an antropyloric transition point without any abnormality at the transition zone.
Okay, let's translate that. Antro is the bottom part of the stomach. Pyloric is the gate to the intestines. So an antropyloric transition point means...
It means the radiologist can see the exact sharp millimeter where the swollen, gas-filled stomach abruptly pinches off and transitions into the flat, empty intestine. But the critical part of the finding is without abnormality.
What does that mean?
There is no tumor crushing the stomach. There is no swollen lymph node. There is no external mass creating the pinch. The only thing causing the pinch is the torsion of the tissue itself.
The tissue is strangling itself. Okay, that's the first sign. What's the second 100% sign?
The second sign is purely orientational. They noted that the antrum, the bottom portion of the stomach, was physically located at the exact same level or higher than the fundus, the top portion of the stomach.
Gravity is entirely reversed. The floor is above the ceiling.
Precisely. When a radiologist looks at the cross-sectional slices of a CT scan and sees those 2 signs simultaneously, the sharp, self-inflicted pinch point and the inverted anatomical orientation, they know with absolute 100% certainty they are dealing with a volvulus. They can confidently call the surgical team and say, take this patient to the OR immediately.
So wait, let me play devil's advocate here and reason this out. If we have these amazing high-resolution cameras that we can pass right down the throat endoscopy,
Right.
why go through the trouble of taking a CT scan from the outside, looking at gray shadows and transition points? Why not just stick a flexible camera down the esophagus, look at the twist directly from the inside in full color, and maybe even use the rigid scope to push the stomach back into place, like the NG tube did for that kid? Wouldn't that be faster and solve the problem without cutting them open?
It is a very logical question, and in a chronic, mild case, endoscopy is sometimes used to diagnose and even attempt to untwist the stomach. But in an acute, severe emergency, it is a highly, highly dangerous proposition. We have to go back to the wringing towel analogy and the concept of ischemia.
Actually, if the blood supply is cut off, that tissue isn't just a tough muscle anymore.
Yeah.
It's probably dying.
Exactly. Healthy stomach tissue is thick, muscular, and incredibly resilient. But ischemic, dying stomach tissue undergoes a rapid physical change. It becomes friable, the cell walls break down, it becomes paper-thin, mushy, and necrotic.
So if a gastroenterologist passes a semi-rigid endoscope blindly down the esophagus and pushes that camera against a paper-thin, necrotic stomach wall, trying to force the twisted doorway open, wouldn't they just punch right through it?
The risk of punching a hole straight through the stomach, creating an iatrogenic perforation, is astronomical.
Yeah.
You are poking wet tissue paper with a stick. And as we discussed, a perforation takes a dire situation and turns it into an immediately lethal one.
Right.
Endoscopy in the acute phase is essentially playing Russian roulette. CT, on the other hand, provides the rapid 3D anatomical map the surgeons need to plan a life-saving operation without ever having to physically touch or stress the delicate dying tissue. They don't touch it until they have the abdomen wide open and can safely control the environment.
That makes perfect sense. Look, but don't touch. Let the imaging guide the scalpel. And that mention of ischemic dying tissue brings us to the ultimate fork in the road for these patients. Because not every twisted stomach is a 5-alarm fire.
No, it's not.
We have to look at the vastly different ways this condition is treated. We are contrasting the knife versus the pill. The life or death acute catastrophe requiring an immediate, massive open surgery versus the chronic grumbling stomach ache that might just need very careful non-surgical management.
The contrast between the acute and chronic presentations of gastric volvulus is so stark, it almost feels like managing 2 completely different diseases. Let's look at the acute emergency first. The sources outline a clinical case that perfectly, tragically encapsulates the terrifying reality of a severe organoaxial twist.
This was a case report from the World Journal of Surgery and Surgical Research.
Right.
We have an 86-year-old man who arrives at the emergency department. He has a history of a hiatal hernia, so he's already at risk.
Right.
He presents with 48 hours of progressive, worsening abdominal pain. 48 hours is a long time for a twisted organ. By the time he arrives, he is dyspneic, meaning he is visibly struggling to breathe. He has hypotension, his blood pressure has crashed to dangerously low levels, and he has tachycardia, a racing heart rate.
Yeah.
The man is in profound clinical shock.
His body is shutting down. Clinically, the ER team attempts the Borchardt protocol. They attempt an NG tube insertion and it fails. It hits the dead end.
Wow.
So they immediately order an MD-CT scan. The imaging confirms their absolute worst fears. It doesn't just show a twisted stomach. It shows a massive pneumoperitoneum.
Let's break that down. Pneumo means air or gas.
Right.
Peritoneum is the abdominal cavity. Free air in the abdomen. That means the balloon popped.
Yes. The 48-hour delay was fatal for the tissue. The trapped gas and acid inside the closed-loop obstruction finally overcame the tensile strength of the necrotic stomach wall. The stomach perforated.
Oh, that's bad.
The gas, the corrosive stomach acid, and all the bacteria from his digestive tract were actively leaking out into the normally sterile environment of his abdominal cavity. They rushed him from the CT scanner straight into emergency surgery.
What do surgeons even find when they open someone up in that state? You can't just casually untwist a dead, torn organ.
They opened his abdomen. The surgical reality was grim. He had diffuse peritonitis. The leaked acid and bacteria had caused a massive systemic fiery infection of the entire abdominal lining. The top of his stomach, the fundus, was not just torn, it was entirely black, necrotic, and destroyed.
So they have to remove the dead parts.
They have to perform extreme damage control. They perform what is called an atypical gastrectomy. They had to systematically and carefully cut away all the dead, gangrenous stomach tissue, ensuring they cut back to healthy, bleeding tissue margins. Once they salvaged what little of the stomach remained, they performed a gastropexy. They took the remaining viable stomach tissue and physically stitched it securely to the anterior abdominal wall. They anchored it down so profoundly that the remaining remnant could never twist again.
They bolted it to the floor.
Exactly.
But the sources note that despite this aggressive, heroic surgical intervention, the physiological shock to this 86-year-old man was simply too great. The peritonitis had already triggered a systemic cascade. He died of multi-organ failure within 24 hours of the surgery.
It is a deeply sobering case. The historical literature notes that before the advent of modern antibiotics and advanced critical care, the mortality rate for an acute gastric volvulus was hovering between 30% and 50%. It was essentially a coin flip whether the patient survived the ordeal.
That's terrifying.
And even today, right now, with modern broad-spectrum antibiotics, highly advanced MD-CT scans, and refined surgical techniques, the mortality rate is still stubbornly high, sitting at 15% to 20%. 1 in 5 people who suffer an acute twist will not make it.
Which perfectly underscores why Borchardt's triad and rapid CT scans are so vital. The urgency of diagnosis is paramount.
Right.
But as we mentioned at the start of this section, there's a second path. What happens if the stomach only twists partially?
Right.
What if it folds mesenteroaxially, causes some sharp pain, and then spontaneously unfolds? Most importantly, what if you have a patient who is old, frail, have a heart condition, and represents a massive, potentially lethal surgical risk? Do you still force them onto the operating table?
That is the modern clinical dilemma. That exact question brings us to a fascinating paradigm-shifting study by Su and colleagues published in the World Journal of Gastroenterology.
Okay, what do they do?
They wanted to rigorously examine the chronic alternative. They conducted a 5-year longitudinal study following 44 patients who were definitively diagnosed with chronic gastric volvulus. But critically, these 44 patients were managed entirely conservatively, meaning no scalpels, no operating room.
It's a very brave study, clinically speaking, because the traditional surgical dogma passed down for decades has always been, if it twists, you must fix it. Because the fear of that acute necrotic strangulation we just talked about is so deeply ingrained in surgical training.
Exactly. The fear of perforation drives the scalpel. Let's look closely at the demographics of these 44 patients because it paints a picture of who gets this chronic version. The median age was 71 years old. A significant majority, 84%, were male. And they were presenting to their primary care doctors or gastroenterologists with very vague, grumbling, non-specific symptoms. 55% complained of a feeling of early abdominal fullness when eating. 57% had generalized dull abdominal pain. 41% complained of non-cardiac chest pain. And 39% had persistent nausea.
It's the kind of symptom list that could literally be a dozen different things. Acid reflux, a peptic ulcer, gallstones, or just bad indigestion from eating too late. It's diagnostic camouflage.
But these patients were all investigated thoroughly. They underwent upper GI barium swallows, and the imaging definitively proved that their stomachs were chronically twisting and untwisting. But instead of scheduling them for a major laparotomy or a laparoscopic gastropexy to stitch the stomach down, the doctors chose watchful waiting.
Interesting.
They prescribed oral medications, specifically prokinetic agents.
What do prokinetic agents do?
They are drugs that stimulate the smooth muscles of the digestive tract. They force the stomach to empty its contents into the intestines much faster. A heavy, full stomach is far more likely to twist than an empty one, so keep it empty.
Makes sense.
They also prescribed anti-secretory therapy, powerful antacids to reduce the volume of stomach acid, and advised the patients to radically change their diet. Eat very small, frequent meals rather than large, heavy dinners. Keep the weight out of the hammock.
And the revelation from this 5-year follow-up study is absolutely incredible. It completely challenges the old surgical dogma.
It does.
Of those 44 conservatively managed patients, 54% experienced a recurrence of their symptoms. The fullness, the dull pain, the nausea, it came back. The median follow-up period before the symptoms returned was about 16 months.
Right.
However, and this is a massive critical takeaway from the entire paper, over the entire 5 years of tracking these 44 patients, exactly 0 patients developed an acute life-threatening complication, 0 organ strangulations, 0 necrotic perforations, 0 deaths attributed to the volvulus.
It is a stunning statistical finding. It proves that the chronic form of the disease does not inevitably lead to the fatal acute form. But this raises an incredibly important secondary question. If it's physiologically safe to leave a chronically twisting stomach alone, why does it keep twisting back and forth in these specific patients?
Oh yeah, why does it keep happening to them?
The Sioux study researchers dug deep into their data and found a fascinating correlation. They ran a regression analysis looking for independent risk factors that predicted exactly whose symptoms would return and whose would vanish.
And the risk factors weren't what you'd expect. Age didn't matter. Whether you were male or female didn't matter. What mattered overwhelmingly was a history of peritoneal adhesions.
The surgical scar tissue we talked about much earlier.
Yes. Patients who had adhesions, thick bands of scar tissue left over from prior abdominal surgeries or from past infections like appendicitis, were far more likely to have recurrent, painful volvulus episodes. In fact, the presence of adhesions increased the hazard ratio of symptom recurrence by 2.58.
So you are more than 2.5 times more likely to have your stomach continuously retwist if you have a landscape of internal scar tissue.
Why does scar tissue cause such a massive increase in the recurrence rate?
Because the adhesions fundamentally alter the internal physics of the abdominal cavity. The organs are supposed to slide smoothly past one another, but a fibrous band of scar tissue acts as a fixed, unyielding pivot point.
Oh, I see.
The wall of the stomach catches on the scar tissue, it gets snagged, and as the stomach contracts, it spins around that fixed point. But more importantly, the adhesion hampers the stomach's ability to smoothly and spontaneously untwist itself. The stomach gets trapped.
That sounds awful.
So the patient gets stuck in this miserable, chronic cycle. The stomach catches on the scar, stretches the tissue, causes the pain and nausea, and then eventually, hours later, slips free again, over and over.
So if someone listening to this has an elderly relative, a grandfather or grandmother who comes home from a battery of tests at the gastroenterologist with this diagnosis, chronic gastric volvulus,
Yeah.
the initial reaction is probably going to be sheer panic.
Of course.
The word volvulus sounds terrifying. The doctor's talking about a twisting internal organ. But the overarching message from the Sioux study is actually profoundly reassuring.
Yes. The clinical messaging changes completely based on the data. For an elderly patient, particularly one with other medical comorbidities like heart disease, diabetes, or poor lung function, the message is, this condition is going to be annoying. It is a chronic burden. The symptoms will likely return.
Right.
You will have to manage their diet strictly, eat small meals, and take medications religiously. But skipping the major open abdominal surgery is a statistically safe and validated bet.
The fear that the chronic folding will suddenly turn into a lethal bursting organ in the middle of the night is, statistically speaking, incredibly low if it is managed correctly with a physician.
It is a complete paradigm shift in how we view the condition. We have to weigh the intervention against the disease. For a frail 80-year-old patient, The raw physiological stress of putting them under general anesthesia, intubating them, cutting open their abdomen, and surgically manipulating their organs might carry a mortality risk that is 10 or 20 times higher than the actual risk of the stomach acutely strangulating on its own.
Wow, that really puts it in perspective.
Conservative management with vigilant, careful follow-up is not a failure to treat the patient. It is a highly valid, evidence-based alternative to the knife.
It's all about playing the physiological odds. Okay, we have covered a tremendous amount of incredibly dense medical ground today. Let's do a quick flyby of the main takeaways from the sources to lock it in.
Sounds good.
We started by exploring the physical, mechanical vulnerability of our stomach's ligaments, how the biological hammock of the gastrosplenic, gastroduodenal, gastrophrenic, and gastrohepatic mooring lines can snap, stretch, or be congenitally missing.
We broke down the critical geometric difference between the ringing organoaxial twist along the long axis, which violently pinches off the blood supply, causes necrosis, and results in surgical emergencies, versus the folding mesenteroaxial twist along the short axis, which is often pediatric, partial, and results in chronic, intermittent symptoms.
We looked at the wild array of causes, from the congenital wandering spleen dragging the stomach out of place, to the acquired irony of a laparoscopic Nissen fundoplication inadvertently creating massive laxity while trying to fix a giant hiatal hernia.
We also looked at the historical elegance of Borchardt's triad from 1904 severe epigastric pain, retching without vomiting, and the failed physical passage of an NG tube and how perfectly it predicts the mechanics of an organoaxial twist.
We contrasted that historical hands-on wisdom with the incredible precision of modern MDCT imaging, specifically the Millet study, which identified the antropyloric transition point and the inverted stomach orientation as having 100% specificity for diagnosis, allowing surgeons to map the abdomen without risking poking a hole through dying tissue with an endoscope.
And finally, we navigated the nuanced, incredibly high-stakes choice between emergency surgery for a dying, perforating organ and the conservative, pill-based, watchful-waiting symptom management that is proving so statistically safe and effective for elderly, chronic sufferers with surgical adhesions.
It is a truly remarkable spectrum of disease, ranging from a hidden, completely asymptomatic anatomical quirk to an explosive surgical catastrophe.
It really is.
Which leaves me with one final thought for you, our listener, to take with you today. We tend to go through life thinking of our internal organs as perfectly evolved, permanent, immovable fixtures. We think of our anatomy like a blueprint, everything bolted firmly into place.
Yeah, that's the illusion.
But as we've seen today, our internal organs are really just heavy, fluid-filled muscular bags suspended by frail, fleshy tethers inside a hollow, moving cavity. If something as vital, heavy, and central as the human stomach can simply lose its moorings and do a 180-degree flip just from the wear and tear of gravity, the aging of connective tissue, or the weight of a wandering spleen, what other vague aches, pains, or instances of what we just call indigestion are we experiencing every single day that are actually tiny, internal mechanical shifts?
Wow.
Next time you have a weird, unexplainable stomachache that comes out of nowhere and mysteriously vanishes an hour later, you might just wonder, is my anatomy currently doing gymnastics in the dark?
It's a sobering but entirely physiologically plausible thought. We are dynamic, shifting machines, and sometimes the internal gears just slip.
The structural vulnerabilities are real. Thanks for joining us on this deep dive.